Hello and welcome to the ImpediMed webinar series. My name is Joanne Yao and I am the Vice President of Marketing with ImpediMed. Today's webinar is titled L-Dex Reimbursement, Best Practices for Building a Successful Lymphedema Prevention Program. We will start today with didactic presentations, followed by a live Q&A session. You may participate by submitting questions via the Q&A icon on your screen at any time during today's presentation. We will answer as many questions as possible during the next hour, and we'll follow up on any questions that we are not able to address live. We're also happy to offer certificates of completion for your participation in this webinar upon request. To request a certificate, you may either respond to your registration confirmation email us at info@impedimed.com, or contact your ImpediMed representative. All webinars are available for replay approximately 1 week following the event. You may find them on ImpediMed's Oncology YouTube channel, and make sure to subscribe while you're there. Today, we're going to hear from 3 expert panelists. Joining us, we have Leslie Vassar, occupational therapist and director of the ProMedica Total Rehab. We have Chelsey Jaworski, senior director of onboarding and reimbursement with ImpediMed, and Chrissy Ferguson, our case assistance and implementation manager with ImpediMed. Now today, Chelsey does send her apologies. She's not able to join us live, but she was kind enough to pre-record her presentation. So we are going to play her recording, followed by a live presentation from Leslie, and Chelsey's colleague Chrissy will join us during the Q&A session to answer any questions. So thank you, and now we'll hear from Chelsey.
Good afternoon, I'm Chelsey Jaworski. I'm the Senior Director of Reimbursement here at ImpediMed. Today we're going to discuss best practices, not only for reimbursement implementation through our internal case assistance program, but also best practices for your own internal site-managed programs. This is in reference to CPT code 93702, the bioimpedance spectroscopy, or BIS, extracellular fluid analysis for lymphedema assessment. The Medicare national average payment is $139.40, and Medicare hospital outpatient is $140. To begin our presentation, we're going to review our internal case assistance program, our best practices, and then halfway through my presentation, I'm going to review site-managed programs. So starting with our internal case assistance program, we really seek to expedite insurance coverage and appeals to drive immediate access for patient care. How we do this? We initiate predeterminations. When we do that, we initiate for a year's worth of assessments. That way, if we have to submit a first level or second level appeal, when they are overturned, they do provide coverage for an entire year's worth of assessments. We track every single case in order to identify trends from each individual payer, whether it be regional or national. This way, we're able to update our resources appropriately in order to streamline our reimbursement process, but also to ensure that we're receiving the proper reimbursement for the sites. Again, when we go through the predetermination process, we do look to exhaust all levels of appeal if necessary through external appeal. And recently, we just did some statistics, and out of the 217 external appeals that we have submitted, we have won 200 of them. So only 17 have gone through external appeal and not been approved. 200 have. So any language within those external appeal wins or independent review, we have updated our resources for best possible outcomes. So this is a step-by-step process. We work very closely with our clinical team members in order to facilitate and implement the reimbursement program along with the clinical implementation. So step 1 is always having the fully executed business associate agreement and/or BAA. This ensures that we are 100% HIPAA compliant. If you're unfamiliar with HIPAA, it is Health Insurance Portability and Accountability Act of 1996. We also have our own very own ImpediMed privacy policy regarding compliance that we are happy to forward over to any site in addition to the business associate agreement. Step 2 is obtaining necessary site information. So you see here on the right, this is our standard intake form that we provide to each individual site when you are going to utilize our program. Basics, the site name, the mailing address. What type of site are you? Are you place of service 19, 22? 22 is normally on-site facility, rehab facility. 19 is off-site, but that's when you bill under your facility's tax ID, or you place of service 11 for their physician's practices. But that's all necessary information for us to know when we're building out your program and especially your workflow. The site tax ID, that's normally the tax ID in which the 93702 will be submitted under, and obtaining the name of your EHR that you utilize. So once we receive all of this information through step 2, we do create a master intake form that we will forward over to you with all the necessary information. You can use patient identifiers, if you will, in order for when either the physical therapist, occupational therapist, or in physician's practices cases, the medical assistant would send over this case assistance form via secure email or secure e-fax. Step 3, electronic health record read-only access. This is best practice for multiple reasons. So first and foremost, in order to submit for read-only access, you have to have a BAA established, fully executed BAA. This, along with an email, an example email that we have, should be submitted to IT, who will then review the request for read-only access and normally provide members of the ImpediMed reimbursement team with a form that they have to complete where they would provide their social security number, their date of birth, all different identifiers, similar to the same kind of forms that you have to complete when you were first hired through that institution. We forward it back to IT, they review everything again, and then a username and password is provided to the internal reimbursement team at ImpediMed. So going back to step 2, with the intake form, when you submit that intake form, that has the patient identifiers on it. So first name, last name, date of birth, and perhaps medical record number. All of this is outlined during the implementation workflow call, but that's how we know what patient to log into your EHR with. We don't log in for any patient outside of the patient name that's provided on that intake form. This is an example of different documents that we like to extract from the EHR in order to support medical necessity when submitting predeterminations or post-claim appeals to the insurance company. As you can see here, there's a new lump identified or occupational therapy visit. They returned for a therapy visit where they did a SOZO. Also plastic consults or pathology report or operating report. One individual site had already uploaded a SOZO document. So that's where they have the SOZO report that they print out and upload into media, and it's identified as SOZO. So we submit all of this necessary supporting information to the insurance company in addition to a very tailored template letter. Now, step 4, after we have all of the basics done, is organizing a call with the reimbursement team. So individuals that should join this call, the hospital facility revenue cycle team, and normally, you know, the titles, they review the claim payments and appeals. Pre-reg teams, those are the individuals that do benefits verifications and pre-authorizations. A member of the compliance team is always necessary. and revenue integrity or in charge of the charge master, because we want to ensure that you are going to incorporate 93702 into your charge master. And everyone should join this particular call so we can go over basic questions related to how your rev cycle team normally handles appeals, how your pre-reg normally handles predeterminations, and understand your compliance and patient responsibility balances. So all of this is discussed on the call. So step 5. This is what we like to provide in order to have a workflow discussion. And I'll review each one individually. So what tax ID is the CPT code 93702 going to be billed under? This is a critical component, as we will decide whoever purchased this particular technology, they should be the ones that are billing this out. Normally it's the facility, and in some instances it is the physician practice. So knowing the appropriate tax ID number in which this should be billed out. Number 2, will the team send all of the payers to ImpediMed, the Case Assistance Program, or only commercial and Medicare Advantage? This is an important workflow discussion. So why we say commercial and Medicare Advantage, best practice is yes, you should do predeterminations on Medicare Advantage and all commercial if available. Identifying a team member who will be sending the intake form to ImpediMed. So that intake form that we reviewed a little bit earlier on in the presentation, it's just standard question. Who's going to be the one that's going to be responsible to submit that particular intake form, when they're going to submit that intake form, whether they identify the patient via schedule, maybe a week ahead of time, 2 days ahead of time, or are they going to send that intake form right after they've done the assessment or the same date of service? You can initiate a predetermination up to the same date of service. Identifying the team member who will provide the patient with a potential for non-coverage waiver, and educate the patient on why the particular commercial payer may not provide coverage for CPT code 93702, but educate them on how the Case Assistance Program will be exhausting all levels of appeal to ensure that that patient is able to have the assessment moving forward. Identifying the team member who will be responsible for all correspondence received from the payer. So although the reimbursement team here does call and check the statuses on all cases, we do have letters faxed to us regularly. Some particular payers will mail correspondences to your individual site, so we like to know where who normally receives the denial letters from the payers. Is it your revenue cycle team? Is it your front desk? Who is that individual at your site that gets those denial letters? Because we do like them to be forwarded to us. So identifying that team member is a critical component. Identifying a team member who will receive our approval letters and upload into your EHR. So whenever we do have an approval letter, we do forward that to the person identified during the workflow discussion. Normally it's a member of the front desk as well as the revenue cycle. And we provide that approval letter along with the patient's name, how many visits it's been approved for, in addition to the time frame in which it was approved. Identifying the team members who will receive biweekly case assistance status report. So we do every single case that you submit through the Case Assistance Program, we provide you with a biweekly case report. Normally it's a member of the front end team and a member of the revenue cycle team. That way you can see if the patient's at predetermination first level appeal, the predetermination was approved for one particular patient, or on the back end if a post-claim denial appeal is at first level, second level. Normally post-claim takes a significant amount of time, those appeals to go through. Sometimes if you have to exhaust all levels of post-claim, it can be upwards of 7 to 9 months. Identifying the team member to reach out to patients when the payer forms require signature. So Aetna, United Healthcare, actually most commercial payers, if you have to exhaust all levels of appeal, you do need the patient's signature to submit an external appeal. Why we want to go through external appeal? Because we have a tremendous amount of success. And anytime we have an external appeal win, I can use that information in my discussions with the medical policy committees. One of the first things we do is review and sign the template letter. So we provide the predetermination template letter, Medicare Advantage, as well as post-claim. We like to have the physical therapist, occupational therapist, or physicians review the letter and make any edits if appropriate and sign that particular template letter. That way we can streamline the process so we don't have to send each individual letter to you. We can submit it to the insurance company right away and expedite the process. Identifying the name of the administrator to provide United Healthcare, Availity, and Navinet portal access. So in order for the reimbursement team to not stay on the phone for hours, as you guys are probably aware, you're on hold for a significant amount of time. United Healthcare portal, you cannot submit predeterminations by way of portal. However, you can check the status of the cases. You can submit levels of appeal via the portal. That way you can ensure that they actually receive the case and expedite the case as much as possible. Availity, a tremendous amount of commercial payers utilize that, as well as Navinet, Blue Cross Blue Shield, Horizon, specifically when submitting predeterminations through the Navinet portal. It has proven to be very successful. So we provide the usernames of Availity, Navinet, and United Healthcare portal to your site in order for the site administrator to provide access for our team members. Will the SOZO be an appointment type or inserted into the notes on the appointment? So this is a process when you purchase the technology and you go through clinical implementation. That's why we work with our alongside our clinical team. So I have a lot of sites that will build out a SOZO appointment type. That way it's very clear and easy for the medical assistant or the PTs or OTs to look into their schedule when they're seeing the SOZO appointment type. Others will insert a note right within that schedule that the patient is going to have that particular SOZO done that day. So these are just, questions that we like to review in order to build out an appropriate and tailored workflow for you for the pre-registration responsibility. Moving on to the revenue cycle responsibilities. Number one has 93702 been incorporated into the charge master. What is the set amount? Normally, the Medicare Advantage average payment is anything from $158 to about $190. Commercial payers, what we're seeing, and of course it's region specific, not every state receives the same reimbursement, but average anything from 200 or actually 178 to about 220 is the average commercial payment. So you don't want to set the charge too high, knowing that your reimbursement is going to be, in the low 200s. Key question is if you appeal all post-claim denials. So what I have found in our experience over the last year is, because this is a charge amount that is rather, it's a lower charge amount outside of, doing a procedure, doing an operation, most revenue cycle teams were not appealing any 93702 when it was denied on the back end. So this is a key question that we like to ask, and why we work hand in hand with the revenue cycle team. Because if you don't normally submit an appeal on a post-claim denial, you're potentially losing out on revenue. Identifying the team members who should receive a biweekly case report. You saw this particular bullet for the pre-registration responsibilities. We like to have the front end and a member of the revenue cycle team just to ensure everybody's communicating and everybody's on the same page. Everybody receives the same case report so they can see in the next bullet or set up an internal queue ahead of time. So it doesn't necessarily, it triggers, the queue will set up to hold patient responsibility. So the thought process is why we send the case report, biweekly case report, to the revenue cycle team. So they can see maybe, there's a Cigna post-claim denial appeal that's still active. That way they can ensure that that hold for that particular patient, that case is on hold, so it doesn't automatically go to patient responsibility. We would hate to have the patient be responsible for something when we are working on their behalf and doing an appeal. Another key component is, are you billing a CMS on a CMS 1500, CMS 1545, or UB04? Yes, the 1545 and UB04 are the same type of form, but this is a critical component on how you're submitting out to the insurers as well as Medicare. Example accounts, receivable report. We like to request and provide you an example report ahead of time to include the ICN claim number and total amount charged, in addition to perhaps the date of service, patient name, or different identifiers with that patient name. If you do not have an ICN claim number or total amount charged when you're submitting a post-claim denial appeal, we have found that the insurance company will just delete your appeal or kick out the claim appeal. So that's why we're always asking for the ICN claim number and total amount charged. We do like to set up monthly calls after you do go live, just to ensure the workflows are streamlined, everything is working well, and just to ensure that the particular claims going out to the payers, some are coming back perhaps from CMS, paid, denied, along with the commercial insurers. We just want to ensure that everything is being submitted correctly after we have set up the proper workflow. Step 7, so electronic needs best practices. Yes, we need to obviously know what EHR you have. We have already established that when we are doing the read-only access, but this is the most critical component in obtaining coverage as medical necessity for 93702. This is an example documentation that can be uploaded. It is otherwise known as a smart phrase, documentation template, or dot phrase, easily uploaded into your EHR. The top line in the red font is where the medical assistant, PT, or OT would insert whether it was a baseline, 3 months, 6 months, 1 year follow-up. The second line with red font is where you would simply add in the assessment value score from that particular day. Everything in black font is to match our Prevent 3-year clinical trial that was recently published in the latter part of January. So again, in addition to the case assistance program, we work with the medical policy committees to get this incorporated into their policy as medically necessary. It's a top-down, bottom-up approach. So we want to ensure that we're utilizing the appropriate protocol, which is why we've developed the smart phrase. So the utilization management, when that report is pulled by the medical policy team, they are seeing the same narrative in my discussions that I'm also having with them on the top-down approach. Second most important thing, once you do upload this to support medical necessity, is where it will be located. So even when you utilize our case assistance program, this is something that we need to know. Is it where is it going to be located? In the physician note? Is it in the PT note? And where are those located? As well as most sites upload the actual SOZO report itself from mysozo.com into their media section. But you'd be surprised to know that most revenue cycle teams don't know where this particular documentation is housed. Therefore, it wasn't getting submitted to the insurance companies to support medical necessity. So this is, number 1 key component is uploading this, and number 2 is letting your revenue cycle team and internal front end know where this is going to be located so it gets submitted appropriately to the insurance companies to support medical necessity. Step 8. Now that we've discussed all of the questions outlined in the first few steps, this is where we start to build out our predetermination workflow and our revenue post-claim workflow as well. So this is an example when we are granted with read-only access. In orange is the site's responsibility. Blue is ImpedMed's responsibility. So in orange, site responsibility, patients identified that the needs associated by the physician. The site sends in the patient name and intake form to the ImpedMed Case Assistance Program. Then in blue, ImpedMed responsibilities, our Case Assistant Program pulls the pertinent clinical data from the electronic records, and we perform the predetermination. If it's approved, and again, we went through this in earlier steps, approved, we forward that approval letter onto your site, and then we actually automatically initiate another predetermination outside of the approval window that was granted by the payer. If it's denied, we exhaust all levels of appeal as necessary. And again, we're providing that biweekly case status report to not only the revenue cycle team, but for the front end team as well. In orange on the bottom, you see the revenue cycle team provides ImpedMed Case Assistance Program with the monthly denial report. So this is specific to denials of the 93702. So that way we can work in parallel if depending on when you're submitting that intake form to us, we can go ahead and work on post-claim denial and appeal for what the initial date of service that was outlined for predetermination if it was denied. Now we're going to move on to site managed programs. I have had a number of conversations with many sites and educating them on the resources that we've developed and trained their individual teams. So I just wanted to provide this information for you as well, because this can be replicated and you can do this on your own. So how we support you for your site managed program. So we develop reimbursement implementation plan. Everything that I outlined through our internal case assistance program, we also review with you, even if you're going to do a site managed program. And we guide you through all the necessary steps for a successful program. We provide you with all of the resources, and you will see all the resources in the upcoming slides that you can utilize in your own internal program. And then we set up, once everything's been developed, we train your site on all of the best practices. We even go a step further, and similar to how we have monthly calls with our case assistance program sites, we also have scheduled monthly calls with sites that do it on their own. We will review if, like a Medicare Advantage denied, what's the best practices on what to do with that. So although you're doing a site managed program, we're still here for you, and we still provide you with all the necessary information when requested. So resources. We have a predetermination request letter, appeal letters, first level, second level, and external appeal, Medicare Advantage predetermination request letters, post-claim appeal letters, individual payer predetermination forms that may be something that you're not normally used to if you are more apt to having to do pre-authorizations, but we will provide them for you related to your own internal payer mix. Phone and fax numbers for the payers for both predeterminations. Most sites are, again, used to doing pre-authorizations, so we have the fax numbers and the phone numbers for all of the payers that will do predeterminations. That way you can submit it by using our resource. Example, revenue cycle monthly report on CPT code 93702. That way when we have our monthly call, your revenue cycle team has that already pulled with the denials that we can help you work through. We create, again, the workflow, everything that we did through the first few steps for the case assistance program, we build out a workflow for you, even if you're going to do a site managed program, and then training. So here are the template letters. Keep in mind each template letter is about 4 pages long. This is to support medical necessity when submitting to the insurance company. So the red font is where you would incorporate the patient's name and clinical information. So we take the patient's clinical information along with the technology information in order to support medical necessity. Predetermination, Medicare Advantage. The one difference with this is absent an LCD or local coverage determination, the Medicare Advantage plan will defer to the commercial medical policy. So Medicare does provide coverage for 93702. So we've gone into each individual MAC or Medicare Administrator Contractor and extracted the link along with the fee schedule, included it into our template letter to show that Medicare is covering this. Therefore, that particular Medicare Advantage should be providing coverage. The post-claim denial appeal letter is similar. You work this if there is a claim denial. Again, this is one of 4 pages. Predetermination request forms. This is just 2 examples. There are several payers that you do have to complete these forms when you're submitting predeterminations. Standard, date of service, physician name, tax ID in which it's going to be submitted under, what type of place of service are you, ICD-10 diagnosis codes, and the CPT code. So this is going to be your cover page essentially to the insurance company, and all of the clinical documentation and example template letter should be submitted to the insurance company to support medical necessity for your patient. And again, depending on your payer mix, we have all of the predetermination request forms that we can forward on to you for your use. Electronic needs best practices, again, the most critical component, and I did review this already, but in site managed practices programs, this is critical as well. So this needs to be uploaded to support medical necessity when billing out the CPT code 93702. As you're aware, you need documentation when you are billing out any kind of CPT code. So that's why we have developed this and submit this to the insurance company. Please, again, when we are building out your workflow, we find out where this is going to be located. So your revenue cycle team knows what this looks like, what they're looking for, and where to find it so they can submit it to the insurance company to support medical necessity and have this particular maybe denied claim overturned. Particular information that the site should send to the payer. So this is broken up with predetermination review and post-service appeal. So again, predetermination, the progress notes, either the physician, PT, OT notes, operation report if available. If it's a baseline, you're not going to be able to send the op report. But pathology, insurance card, the SOZA report with documentation once performed, the template letter, and predetermination payer form that we just reviewed. Post-service, again, similar progress notes, op report, pathology report, insurance card, SOZA report with documentation. But again, I will say the ICN claim number and total amount charged is critical. Otherwise, the insurance, if not included, the insurance company will kick out that appeal. There are some commercial insurance and Medicare, obviously, that do not, there's no pre-service review available. So Medicare, Cigna is a big one. UMR, which is a United Healthcare product. Blue Cross Blue Shield Illinois, Blue Cross Blue Shield Texas, CareFirst, Blue Cross Blue Shield in Maryland, Colorado Medicaid, and Blue Shield of California. So why this is important to know, and we do review this during workflow calls for site managed programs as well as the case assistance program. Absent predetermination being provided or submitted, this will automatically most likely come back denied on the back end. So that's why we have the revenue cycle team, provide a monthly report, not only to your internal team, but for us as well to review during our monthly call to ensure we're submitting the post-claim denial appeal on all of these mentioned payers as soon as possible, because there is a time frame window in which you can submit appeals. When doing so, Cigna has been overturning post-claim denials at first level appeal. UMR is similar, Blue Cross Blue Shield Texas, Illinois, similar. But without having, being engaged with your revenue cycle team and not knowing if these have been denied, we all need to work together on getting these post-claim denial appeals submitted. We've been also noticing, just for your reference, that when exhausting all levels of appeal on post-claim side, it's been taking anywhere from 7 to 9 months when exhausting all levels of post-claim appeals. So this is just an example navigation flowchart that we provide to the pre-reg team or front desk, front end. Must be initiated with the payer up to the same date of service. So again, knowing during the workflow discussion when you're going to be looking in your schedule, or are you just going to do the assessment and submit the pre-D the same date of service. Everything on the left box, submit the following to the payer, is already outlined there. Just a reference to call the payer to check the status 1 to 2 days after the case has been submitted. If approved, forward and include that approval letter into your EHR, and denied, then move automatically to the first level appeal. This is the example payer list of phone numbers and fax numbers that I was referring to on the left-hand column, and this is an Excel sheet, easily sortable for you. Payer name is on the left-hand column. There's a column if pre-D, if you can do a predetermination. If there's a form that is required for it, also is a separate column. Then you have the telephone number, the fax number, the post-claim fax number, and there's also a column for mailing address because some post-claims have to be mailed in. So this will be provided to you depending on your particular payer mix. Medicare Advantage and commercial workflow, again, just an example. Visits scheduled, patient is identified to have the SOZO, and it's been inputted as the SOZO appointment type. The clinician takes the SOZO measurement. The pre-reg team identifies if the patient needs a pre-D and obtain all resources to submit. Then the pre-reg submits a predetermination with the payer. Pre-registration checks the status of the predetermination. Rev cycle team generates the monthly report for 93702. They provide the report to the site contact on a specific day of the month. That way they know it's coming. The front-end team reviews the report for payment and denials. And then the error team appeals post-claim denials utilizing the resources provided by ImpediMed. So key takeaways here: in order to optimize your reimbursement, initiate predeterminations with commercial and Medicare Advantage payers. Upload the smart phrase to support medical necessity when billing out CPT code 93702, and have your revenue cycle team and your front end team know where that is located to support medical necessity. And always work with your revenue cycle team to provide you with monthly payment and denial reports.
Hello, my name is Leslie Vassar, and I'm going to be presenting the next section. I am director for ProMedica Total Rehab. ProMedica is an organization that includes 11 acute care hospitals, Paramount Healthcare Insurance, ProMedica Senior Care, formerly HCR Manor Care, ProMedica Physician Group of about 800 plus physicians, and 26 outpatient rehab locations in Northwest Ohio and Southeast Michigan. Next slide, please. So really our patient care goals for having our SOZO was to reduce the incidence of severe lymphedema. Really, it was important to us to begin. We've been trying to get to getting people in earlier, identifying lymphedema well before it becomes a problem. So this was a key piece for us to be able to do that, identifying and treating patients at that subclinical level. We also wanted to develop an affordable screening program that could accommodate the most possible patients, and also identify other cancer rehab related needs through the interaction with the therapist, which was something we didn't really have included in our plan when we first started, but has been something that we have really seen as an important aspect as we have grown our program. Next slide, please. So we began to offer the SOZO at our busiest lymphedema site, which is Total Rehab at Flower Hospital, in December of 2019. So just to give you an idea of what our lymphedema site is, it's a pretty big one. It's the biggest one in the system. We have 3 full-time OTs and 1 full-time CODA who participate in the lymphedema program, who their caseload is primarily lymphedema for the whole day, all day, every day. In 2001, we received 836 lymphedema referrals. That does not include our SOZO referrals. And we actually saw 3,631 visits. You know, it's been pretty busy. We're pretty busy. And so we knew that we wanted to continue to grow that program and identify people earlier, help to make sure we weren't seeing people only after they were a train wreck. So initially, when we started this program back in 2019, Medicare and Paramount Healthcare, which is owned by ProMedica, were the only ones that were consistently paying for the 93702. So at that time, we offered an option of what our own revenue cycle calls a competitive pay rate to patients whose insurance verification revealed they didn't have coverage. So we always do a verification on every patient. And if it said it wasn't going to be covered, then we went ahead and did the competitive pay rate. And we set that based on our own internal compliance recommendation based on the Medicare rate, which you heard during Chelsey's presentations, about $140. So that's kind of where we were at. And even though this is not a horribly high rate, it did definitely create some inequity, as some patients didn't have the ability to pay and were opting out of screenings. You know, basically how I sold this to our revenue cycle is these patients are going through cancer treatment. They have a lot of bills. They have a lot of things going on. It's already a very stressful time for them. So let's figure out how we can find a way to help them out so that lymphedema doesn't have to be another thing that they have to deal with. And also, as Chelsey mentioned in her presentation, internally, these denials weren't high enough to trigger automatic appeals within the system. We're a pretty big system. And to them, you know, this wasn't a high enough dollar amount to trigger that automatic appeal. So when I first reached out to our revenue cycle team, they said, we don't need to work with ImpediMed to do this. We already have a program in place. But we began to realize, I helped them realize pretty quickly that really those were just dropping to self-pay for patients, and it was creating this inequity. So we began to explore the option of carving out these patients for the case assistance program in summer of 2021. And we received approval, got through all the steps that Chelsey talked about, and began submitting cases in October of 2021. Next slide, please. So just to kind of give you an idea, no reason to recreate the wheel. This is kind of how we went through and established our workflows together in calls, mini calls with ImpediMed, our compliance department, revenue cycle, and our total rehab team. So we use Epic. So what the revenue cycle did was created a billing indicator in Epic that automatically gets placed on all accounts that have a 93702 on them. This billing indicator routes to a specific patient account work queue that Rehab works at least weekly. This billing indicator, it's important to note that it doesn't hold claims for claim edits or payer submissions. So it doesn't slow down that part of the revenue process. The billing indicator does hold patient statements if the claim is denied. Then we send identified encounters to ImpediMed via a case request form. Again, we do the prior authorization whenever possible, but we also send them a form and let them know when we've had a denial. And then we also verify on the Rehab side that the dollars are sitting in the insurance bucket and not in the self-pay until they're approved or denied. So once we go through that process, sits in the bucket for a while, and ImpediMed takes over. And so they file the authorization appeal or claim appeal and work through that until we've exhausted all the appeal options. And we get regular emails, both to Total Rehab and to the regular revenue cycle with updates on cases. Additionally, our Epic team was able to build a report that automatically generates all payments that have come in for that month. So not necessarily tied to the month that it was done, but the month that it was paid. And we get that once a month and then send that on to ImpediMed. If the case is approved, it's overturned, so we get approval. We do request reprocessing with that approval letter. I will tell you that a majority of the time they don't just automatically reprocess it if they approve it. And then we assure that any remaining balance is moved to self-pay. If it is ultimately denied and we've exhausted all options, then we do still apply that pricing adjustment and bill the patient at our competitive pay rate. Next slide, please. So at any given time, we have, I said about 85 to 90 patients in our work queue. And when I started doing these slides, I don't know, 3 weeks ago or so, we've actually seen that go up because our volume is increasing at a very rapid pace. In May, we had 53 SOZO visits, either initial or repeat visits. And so we were doing about 2.5 of those a day is our average. So our number in our work queue has gone up recently. We're at about 115 to 120 right now. A majority of these are new patients who are waiting for billing to be processed by the insurance. So we bill once a month on the 5th day of the following month. So for instance, all the May charges just dropped at the beginning of this month. A majority of the April are still sitting in there, haven't processed through yet. So majority of the ones that are in there are just waiting. The remainder of the patients are in active appeal. Those tend to stay in the work queue. I said 2 to 4 months, but it's really probably longer, especially if we don't get appealed on the first time. We have some that have been in there, since we started back in October. And I just regularly update those when we get the case. I just put an account note on there just to let our billing team, revenue cycle team know where we are in the process. And again, we get those bi-weekly case reports and have bi-weekly meetings to discuss the issues, concerns that we have. So just to give you an idea, from December of 2019 to May of 2022, we had 349 new patients appointments scheduled. We performed, or we had scheduled 952, sorry, a little dyslexia there, 952 follow-up appointments scheduled. And this is the director, the manager, and me coming out. The important things, is it worth it? Do we do we make money on it? Does it make sense? Aside from, what's good for the patient. And it does, because we actually have our new patient appointments for SOZO have one of the lowest cancellation rates at 12%. And I will tell you, for every other kind of evaluation, we're much higher than that. Evaluations tend to be one of our highest cancel no-show rates. And this one is really, really low. So, that it's very important to patients. And we hear from our breast care surgeons all the time that patients come in and they want to know, what are we going to do to prevent lymphedema? And so it's really nice to have that. They're super glad we have this so that they can send patients over. Next slide, please. All right, I may be a little OCD here, but for me, especially when we were getting started, it felt a little loosey-goosey for me. I oftentimes didn't want to have to go back into Epic, look at the notes, try to figure out where everything was. So I created this tracking list that I just kind of made generic, but you can kind of see this is actually our tracking list. And so I put in the patient's name, their insurance number, the date of service, and when it was sent. And then I update the remainder of the information, including the ICN, the charge amount, the paid amount, those kind of things. And just discussions and results as well. And so that really helps me out, so that when we get a question about it or a patient comes back in, this is on a common drive. So I, in our front office, can take a look at, do we have an approval number? How many visits were approved, or during what timeline? And we can see there. And then you can actually see on this report, just kind of left this on here so you can get an idea. Those are our actual paid amounts that were approved from this program. So really, I do this. It complements the work queue and the patient tracking. It facilitates the tracking of the patients once they're out of the Epic work queue, because sometimes the patients will come back in it later, and we need to look back through, and it's easier to do it here than to go into Epic, look them up, again, go through their history and the different visits and those kind of things. And it also has allowed me to evaluate progress and trends over time. So just as you're looking at this, I realize I call it Clown College, like it looks a little Clown College, lots of colors. So if you see on here that's green, it means to me and to the team at ImpediMed that it got paid. The red means it was a denial. The white is a new case. And like there's one you can see is a yellow, and that was a brand new case that just paid. And so I send this about once a week back to the ImpediMed team, just so that they can immediately, if we get a denial, start working on the appeals, or let them know that they can remove that patient from their list as somebody who needs their attention. Okay, next slide, please. So success is important. So how do we do that? We really work hard on maintaining our relationship with our business office, our rev cycle team, to work out any bugs. So even that when we first started, when denials were coming through, they were still going to the biller work queue. So the billers were dropping the charges immediately into self-pay, and we didn't catch a few of them. So bills went to patients, and it just got to be a little problematic. So we made a decision with the rev cycle that we would not automatically put those into the biller work queue if it was denied for certain reasons. And so those would just go into our work queue, and they would know we were working that piece of it. Like I said, I use my patient list to compare to the report I get from ImpediMed to make sure no patients have slipped through. Despite our best efforts, it does sometimes happen. Our front office is really good about, as soon as they schedule a patient, they fill out the form and they send it over. And also, I said I really like it to track and trend, and that way we know who the problem children are. We're still definitely, and I know Chelsey's working really hard at this, and her team, They are working really hard to get more of these national payers on board. We are starting to see some good progress with Aetna Medicare. We're starting to get approvals for those. We got our first approval from Aetna POS2, which they had not approved anything up until recently. Anthem, Blue Cross Blue Shield, Blue Cross of Michigan, those are the blues are, I don't know, they tend to be about 50-50. It really looks like what plan they have. Cigna, Medical Mutual, TRICARE, and many of the Medicare Advantage plans just still haven't caught up. And so we have to submit a lot of them for the Advantage plans for appeals. So we do have some, we also know who our regular payers are. So our Ohio Medicaid pays, and we really don't have any problems with them. Front Path is a regional repricing agent, and they pay. United Healthcare is really good. I'd say about 90% of the time we get that, no problem. Of course, Medicare and the Medicaid, including our community plans. Next slide, please. So tips and tricks to be successful as you're going through this. When they asked me this, I said, oh, first of all, I have to say the ImpediMed staff has been really great. They did just what Chelsey was discussing. I mean, that's exactly the kind of things we went through. And then we've got a great team. You guys get to ask questions to Chrissy later. She's part of the team that I talk with all the time, and they've been really great. But we worked really hard initially to get our staff, their staff access to the insurance websites to be able to pull things for us and into our EHR as quickly as possible. Know that it's probably a multi-step process. We find problems, we fix problems. So, but this really does reduce the workload in pulling and sending records, because until that happened, you know, our front office, myself or my manager, Doug, were pulling and sending those. Getting your front end registration involved, so the forms are set as soon as the SOZO is scheduled. So the prior authorization request is received by ImpediMed prior to the visit. That's a big key. You know, we really had to drill that in, hardwire that, so that was happening consistently, and they're really good about that. I think a work queue really reduces the work of finding the patients in the EMR. They're all in one spot. You can quickly run through. I go to my list, look in hospital transaction inquiry, flip through everybody in my work queue, and I can see anybody who's had a recent update, payment, or denial when they're in there. We do still have patients sign a notice of potential non-coverage form, explaining that we will submit to insurance and do an appeal, but if we exhaust our appeal, they are still responsible for our self-pay rate. And that has been really successful. I mean, we do occasionally still have somebody who doesn't want to accept that responsibility, but it has gone from, I don't know, 50 to 60% of people who decline to probably 5%. And then communication is key. The ImpediMed team has been very responsible to emails or calls. We've really worked out processes to make sure that we're working efficiently and not duplicating efforts. And they have a really great customer service focus, and I really appreciate that. They never feel like us reaching out with a question is a bother. They know that they can reach out to us anytime for what they need, and really our focus is on the patient, making sure that we get the coverage and the patient has a good experience. So it's been working really well. So, all right, next slide. Just again, this is my rehab director site coming out. Since we started this process, we've already recouped about $10,000 in net revenue as of the end of May 2022. And so these are ones that would have just either got billed to the patient, we would have written off. so this would have been lost revenue if we hadn't done that. And this only really includes the actual denial that was overturned and not the future revenue that we secured due to the decision. I don't know if you guys noticed on my form that I had, but there's a lot of times where we'll get this one overturned, and then we also already have 4 additional visits approved for the patients. So it's great, so you can extrapolate what that would look like over time. Our patient satisfaction has been really high, and we've seen a reduction in the cancellations due to out-of-pocket expense. Again, we have about a 4% cancellation rate for the new patient and 16% for follow-ups over the last 2 months. So the number I gave you before was kind of over a broader time, but really over the last 2 months, you can see how great our attendance rate is for those patients. And we have identified a 12% increase in our referral rate to therapy with this program. So about 12% of the people that we've screened, we've identified have a subclinical, are reaching in that level where we need to see them. And so we request orders for those patients and then see them in our program. Additionally, I wasn't able to get specific numbers, so this is going to be completely anecdotal, but we are starting to collect this. But what we're finding is because our therapists are doing this, it's not being done in the physician office. They come see our therapist. And so they're spending a little bit of time with their therapist. So they're talking about, oh, how are things going? How are you feeling? How's it been since your surgery? And they're identifying frozen shoulders, swallowing problems, balance issues, all these kind of things that generate referrals to therapy, in addition to concerns that we can take forward to the physician that maybe they need to go see a different specialist, they need to go back to the doctor, those kind of things. So that has been sort of an unexpected benefit that we've had out of the program. Our physicians are really happy that we have this in place, and we've seen a steady rise in the number of physicians who are referring. And our breast surgeons are definitely our champions. We have, they probably account for 80% of our referrals that we have. And it's been so successful that we have the other hospitals in our system and our Cancer Institute for this year, that one of the goals that our Cancer Institute set for our reaccreditation was that we would investigate bringing up a second site. And we've already done that as of May. So not only did we investigate it, we got it done really quickly, and we brought up our second site up in Monroe, Michigan in May. And they just started scheduling patients at the end of May. So went through that whole process. And once we had it down, it was pretty easy to bring that second site up. And I anticipate, I already have at least 2 other hospitals that have reached out and want to be next up on our list. So I anticipate we'll add at least 2 more hospitals as we move forward. So anyways, that's all I have. So feel free, if you have questions, to contact me through your ImpediMed representative. And if I can answer any questions, or if Chrissy can, I guess now's the time. Thank you.
Thank you, Leslie, for your presentation. And Chrissy, thank you for joining us as well. We are over time, and we like to end our webinars on time, but I would be remiss if we didn't reserve at least one question for each of you. And we have a couple of questions coming through Q&A, but Chrissy, I'll start with you. One of the questions we get from customers is, there's SOZO with L-Dex is one lymphedema detection technology, but there's other ones out there as well. Can how does the code 93702 work for other technologies? And you're on mute, Chrissy.
I'm sorry. The code description for CPT code 93702 is specifically bioimpedance spectroscopy, extracellular fluid analysis for lymphedema assessment. It specifies the use of the bioimpedance spectroscopy, which is the technology used by SOZO and L-Dex. Some of the other products use a different form of bioimpedance called bioimpedance analysis. Some do not use bioimpedance at all. So since 93702 is specific to the bioimpedance spectroscopy, it will not apply to the other products.
Thanks, Chrissy. That's really helpful. We get that question a lot. And one of the questions that came through had to do with how, if you're part of the case assistance program like you are, Leslie, how often do you submit requests for predetermination? How many can you do at a single time? So do you do it in advance? Do you do it the day of service? How many do you typically send at one time? Can you talk a little bit about those mechanics and workflow issues?
Sure. So we try to do those as we schedule them. So just today, for instance, I know that my front office submitted 3 that are coming up. Anywhere from, one of them was for tomorrow, the other ones were for next week. So we will submit them kind of as they come in. And we don't try to batch them. We just try to send them in whenever, and that way we're less likely to do that. But I think already this month, we've submitted 9 new patients.
Interesting. And how does it work? Thank you, Leslie. So you're submitting them kind of as they're getting scheduled. So that's really helpful. And then Chrissy, Leslie made a comment about she's getting approvals for multiple cases up front. So when you're requesting predetermination approvals, what are you asking for from the insurance companies?
We are asking for a year's worth of visits, and we ask for 4 visits at that time. So if we call the insurance company, we tell them the date of service is June 18th. So we request June 18th of 2022 through June 18th of 2023 with a total of 4 visits.
Okay. So in that case, yeah, those patient visits do need to be scheduled before you can submit a predetermination request.
Yes, ma'am.
Okay. Thank you. That makes a lot of sense. The other question I think that came through Q&A is specifically related to a question about Southern California. So we will put you in touch with our local representative to help you get that question answered. But I think we're going to wrap up here. It was wonderful content coming through. I'm going to give both of you a chance to just give your final statement on best practices for using case assistance and ultimately getting that best outcomes for patients. And Chrissy, I'll let you go first, and then Leslie, I'll let you go last. Please go ahead, Chrissy.
So best practices are definitely getting those predeterminations submitted in time. So you have the approval going forward. So the patient's approved for a year, so you're okay. And the second one is that smart phrase. So having that smart phrase documented in your cases showing medical necessity has been a tremendous approval rate for our claim appeals.
Thank you, Chrissy. And Leslie, from your perspective, any last comments on why you're doing this for patients, the benefits you've seen, and then what advice you might offer to others who are looking to embark on this path?
Yeah, so I think that really it's all about patient care and providing some healthcare equity to people, whether or not they can afford to pay out of pocket for it, really making sure that they can utilize their benefits and provide these services. To me, it's all about trying to help prevent a long-term chronic condition before it starts. So it's really all about helping those patients with their quality of life. And that's the bottom line for us in rehab.
Thank you, Leslie. And thanks everybody for joining. We hope you found this informative and educational. We will send a replay out to everyone who attended and registered the event. And you can always go to impedimed.com to find replays of past webinars as well. Thank you, Chrissy and Leslie. Really appreciate your participation.
Thank you.